Bismillahirrahmanirrahim. Today we will have case quiz number 120. Case data: 52 years old female referred for assessment of possible glomerulonephritis, as we will see in the history and examination. The patient had 3 months history of bilateral lower extremity rash with intermittent right knee pain with swelling, and 2 years history of fevers and sweats. The patient was treated with a short course of oral prednisolone by her family physician with effect, but hair rash and symptoms returned soon after cessation of the treatment of steroid. Examination of the case revealed palpable petechial rash in her lower extremities, moderate effusions in her right knee and ankle which were warm to touch. The remainder of her examination, including vital signs, was within normal limits. Investigations: the patient had microscopic hematuria. Creatinine was 94 micromole per liter, and the baseline for the same patient was only 59 micromole per liter last year. The patient had normocytic anemia with hemoglobin 10.2 gram per deciliter. The patient had mild leukocytosis with white blood cells 11.12. Urine analysis revealed trace proteinuria, and urine microscopy showed 58 red blood cells per high power field and acanthocytes and 7 white blood cells per high power field. ESR was shooting 115 mm for the first hour. C-reactive protein also shooting 94 mg per liter. Rheumatoid factor was high, but anti-CCP was negative. ANA was weakly positive with a titer only 1/80 by immunofluorescence. RNB was weakly positive, but anti-double strand was negative, and lupus anticoagulant also negative. ANCA C3 and C4 were within normal limits, so negative also. A previously arranged biopsy of her petechial rash was consistent with a leukocytoclastic vasculitis, and immunofluorescence was positive for dermal capillary IgM and C3. Arthrocentesis of her knee was not consistent with a crystalline or infective arthropathy. Hepatitis B, hepatitis C, HIV, and syphilis serology were all negative, so it is not one of these infections. Serum protein electrophoresis didn't show a monoclone, and cryoglobulin were negative. Kappa and lambda light chain were minimally elevated at 15.2 and 12.6 respectively. 24-hour protein show microproteinuria with 320 mg per 24 hour. Renal ultrasound show normal side kidneys without increased echogenicity. Renal biopsy by light microscopy we see immune complex mesangial proliferative glomerulonephritis, diffuse global mesangial hypercellularity was seen. Immunofluorescence show trace mesangial IgG and kappa +1 IgM, lambda and C1q and +2 C3. Electron microscopy showed mesangial electron dense deposits. Her pathology findings were felt to be potentially be in keeping with mesangial proliferative lupus nephritis. However, it was acknowledged that clinical and laboratory findings supporting this diagnosis were lacking. Regarding therapeutic follow-up of this patient, the patient was steroid dependent. Creatinine responded to prednisolone but raised again when with steroid tapering, whatever the steroid-sparing drug used. For example, the patient received azathioprine but didn't tolerate due to gastrointestinal upset. The patient received MMF, which alone didn't improve the case in the absence of steroid, and also rituximab didn't improve the case in the absence of steroid. So the patient responded only to steroid, and every time the steroid was tapered or withdrawn, the condition recurred again. So, what is the diagnosis? The answer is one of the differentials of lupus nephritis, but in patient didn't fulfill the criteria for lupus, and the patient had a hidden infection. So think a while, but the answer will or may surprise you, because the answer is Q fever. Now to complete the case scenario. Her lupus diagnosis was reconsidered given atypical clinical features and her inability to wean off prednisolone. Further infectious workup, including transthoracic echocardiogram, computed tomography scan of the abdomen and pelvis, and repeat blood cultures didn't reveal any infectious source. She was referred to an infectious disease consultant who ordered additional investigations, including Q fever, which ultimately returned positive, with phase 1 IgG 1 to 1892, phase 2 IgG 1 to 8192, but phase 1 and phase 2 IgM below 1 to 16. Despite living in rural settings, no direct zoonotic exposure was identified. Based on the pattern of phase 1 and phase 2 antibody titers, in conjunction with the patient clinical course, the infectious disease team felt this presentation was most in keeping with long-term Q fever, and initiated treatment consisting of doxycycline 100 mg BID and hydroxychloroquine 200 mg TID. Simultaneously, her prednisolone was weaned off gradually. Early in her Q fever treatment course, she underwent a revision of her femoral crossover graft due to occlusive thromboembolism. The patient had previous history of femoral crossover graft. Intraoperative cultures were negative, but her Q fever treatment duration was extended to 2 years, as the infectious disease team felt her vascular thromboembolism was likely in keeping with endovascular Q fever infection. While being treated for Q fever, her creatinine decreased to 60 to 70 micromole per liter. Her hematuria and proteinuria disappeared, and her subjective fevers and chills resolved in conjunction with falling Q fever titers. Hydroxychloroquine and doxycycline were discontinued after 2 years, but were restarted shortly thereafter due to a rising Q fever IgM titer, with a plan for likely lifelong therapy. Discussion of the diagnosis. A Q fever is a zoonotic illness caused by the gram-negative bacteria Coxiella burnetii. Typical bacteria reservoir including sheep, cattle, and goats, although infection from exposure to other animals have been reported. Human infections typically occur following inhalation of aerosolized bacteria and can be either acute or long-term illness. Clinical presentations are highly variable and depend on the strain of Coxiella burnetii in addition to the host factors. Signs and symptoms of acute Q fever infection tend to develop following a 2 to 3 week incubation period and may include flu-like illness, pneumonia, and/or hepatitis. But less common but potentially life-threatening presentation of acute Q fever, including meningitis and pericarditis, have also been reported. Long-term Q fever is often associated with hematological spread and may manifest clinically or as endocarditis, osteomyelitis, and or endovascular graft infection. Endovascular graft infection. While renal dysfunction is not classical Q fever presentation, case reports have described an association between glomerulonephritis and long-term coxella boniti infection. Herein, we describe a case of glomerulonephritis ultimately attributed to an occult long-term Q fever infection. Long-term Q fever is an uncommon zoonotic infection which has been associated with glomerular injury in the literature. Here we describe a case of immune complex mesangial proliferative glomerulonephritis initially felt to be related to a class 2 lupus nephritis, but later determined to be a result of long-term Q fever potentially from an endovascular source. This case highlights the difficulty in establishing the diagnosis of Q fever as a result of non-specific symptoms and high degree of variability in clinical presentation. In addition, Q fever may be overlooked when infectious causes are considered as coxella boniti doesn't stain with the traditional gram techniques and require specific blood culture media to grow. So you will not find a positive test for Q fever unless you thought of it before from the start. The association between Q fever infection and glomerular injury has been previously described in the literature. We identified 11 cases of long-term Q fever associated with biopsy proving glomerular injury in the literature over a 60-year time period. Outcomes for these patients were variable. 6 patients died, 3 had resolution of renal impairment, and 2 had partial improvement in renal functions. The mainstay of treatment was tetracycline class antibiotics in 69% of cases, with additional treatments including lincomycin and immunosuppression. Renal biopsy comparison was limited by variation in biopsy technique analysis and reporting given the long period of time between the first and last published cases, 60 years, I seen before. Previously published light microscopy findings typically show mesangial hypercellularity and or proliferation, which is similar to the light microscopy results in this case, in the current case. 8 cases included IF finding. IgM was found in 88% of the cases, often in association with C3. Our IF findings were consistent with those previously published and demonstrated both IgM and C3 in addition to IgG, C1q, kappa, and lambda. A full house pattern was not seen but has been reported previously in a patient with long-term Q fever infection. Only 3 previously published cases described electron microscopy findings. Full process effacement fusion was seen in all 3 cases, whereas subendothelial electron-dense deposits were seen in 2 cases, and the mesangial electron-dense deposits were seen in the remaining case. Our electron microscopy findings included electron-dense mesangial deposits. However, unlike prior cases, food process effacement was not noted. I mean by our electron microscopy the current case, not myself case. It is not my case. It is a case I brought to you from the literature. I mean by our case the current case in the quiz. In the current case, the patient's early improvement with immunosuppression was felt to support the underlying diagnosis of mesangial proliferative lupus nephritis and led clinicians away from the alternative infectious cause, as it may seem counterintuitive for infectious process to improve with immunosuppression. It is uncommon that infection improve with immunosuppression. It is very, very uncommon. In this case, it is likely that repeated improvement with prednisone represented suppression of the immunological response to a long-term infectious process, leading to the diagnostic confusion. Challenging medical cases have a tendency to evolve over time as new information become available. Stepping back to reconsider a complex case using information not available at its onset can help identify inconsistencies with prior diagnostic reasoning, which may lead to an alternative diagnosis. So, if the case is not typical, you should revise your diagnosis. In the current case, this led to a reconsideration of the infectious cause, a diagnosis of long-term Q fever, and appropriate treatment with normalization of renal function and improvement of the case. So the key message of this case are: this case highlights two important teaching points. First, it stresses the importance of formulating a broad differential, especially in light of a typical clinical presentation, which may be revisited in the event of an uncharacteristic response to treatment. In the current case, the diagnosis of mesangial proliferative lupus nephritis was made after renal biopsy, as an initial workup failed to identify a clear alternative cause. However, despite appropriate initial therapy, our patient didn't improve as expected, prompting a re-evaluation of the case, which ultimately led to correct diagnosis and management strategy. So, repeat again, if the case scenario doesn't follow the classical pathway, you should revise your mind, you should revise your diagnosis. The second teaching point is that glomerular injury secondary to infectious causes may respond at least in part to treatment with immunosuppressive therapy, and the golden rule that infection will flare up with immunosuppression is not 100% accurate, it's not 100% correct. And finally, of course, thank you very much for your attendance, and we will meet you tomorrow with case quiz number 121. Wassalamu alaikum wa rahmatullahi wa barakatuh.